Hey everyone, so if you're getting ready for the NCLEX, you already know that cardiovascular questions are a really big deal. In this explainer, we are going to build a rock-solid understanding of peripheral arterial disease, or PAD. My goal is to turn all that complex pathophysiology into simple, memorable concepts that are actually going to stick with you on exam day.
So here's how we're going to break it all down. We'll start with the absolute basics. What even is PAD? Then we'll get into the why and how it happens. From there, we'll talk about what you'll actually see at the bedside, the signs and symptoms, before jumping into diagnosis and management. And of course, since this is all about the NCLEX, we're going to spend a lot of time on your nursing priorities and finish up with some key clinical judgment pearls to really tie it all together. Let's get into it.
Okay, so first things first. Before we can even begin to talk about symptoms or treatments, we have to have a crystal clear picture of what peripheral arterial disease actually is. I want you to think of it like a plumbing problem, okay? Atherosclerotic narrowing. That's just a fancy way of saying the pipes, your arteries, are getting all clogged up with plaque. And peripheral just means it's happening in the pipes that are furthest from the pump, so we're talking mainly about the legs. And what's the result? Well, you get a massive traffic jam for your blood, which ends up starving the tissues downstream of all that good oxygen and nutrients. If there's one thing you write down, this is the core equation you have to remember for the NCLEX. At its heart, PAD is simply arterial insufficiency. The arteries just can't supply enough blood to meet the demand, and that leads directly to ischemia, which is just the medical term for tissue starvation. When your leg muscles are screaming for oxygen they're not getting, they start to hurt. It's that simple. All right, so we've got the what down, it's arterial insufficiency. Now let's dig into the why and the how. Understanding the risk factors and the process behind it is absolutely key to connecting the dots to the symptoms we're about to cover. You're going to recognize this list from a bunch of other cardiovascular conditions, but for PAD, you have to mentally circle, highlight, and put a giant star next to smoking. It is, without a doubt, the single most powerful risk factor. Why? Well, nicotine is a potent vasoconstrictor. It literally squeezes those arteries shut, while all the other junk in cigarettes damages that delicate inner lining, making it super easy for plaque to build up. And here's a huge NCLEX takeaway for you. PAD is not just a leg problem. It's a whole body problem. If the arteries in the legs are clogged, you can bet the arteries in the heart and brain are too, putting these patients at a massive risk for a heart attack or a stroke. This slide shows the domino effect perfectly. It all starts with that plaque. That plaque narrows the artery, and that creates a bottleneck for blood flow. Now at rest, things might be okay, but the second that patient starts walking, their muscles start demanding way more oxygen. The narrowed artery just can't keep up. And that critical mismatch between oxygen supply and demand, that's what triggers that ischemic pain. And if this goes on for years and years, that chronic starvation leads to permanent tissue damage. If you're going to write one thing down from this whole section, let it be this. It is the absolute simplest way to frame the entire disease process. Blocked arteries lead to starving tissues. Every single symptom, every complication, it all comes back to this one central idea. Okay, we know the why and the how. Now let's get practical. What does a patient with PAD actually look and feel like? What are those key signs that you as the nurse really need to be able to spot? This is the hallmark symptom, the classic sign of PAD, intermittent claudication. Your patient might say something like, my calves just start cramping up after I walk about a block. The really crucial clue here is that it's predictable, and it reliably goes away when they stop and rest for a few minutes. And why is that? Because when they rest, the muscle's oxygen demand drops right back down to a level that the narrowed artery can actually handle. All right, everyone, listen up. This slide right here is absolute exam gold. The 6 Ps. This signals an acute arterial occlusion, which is a limb-threatening emergency. This is not the same as that chronic claudication we just talked about. This is a sudden, catastrophic blockage. We're talking severe pain, a ghostly white pallor, no detectable pulse, that pins and needles feeling of paresthesia, an inability to move the limb or paralysis, and a limb that's cold as ice, that's Poikilothermia. If you see this constellation of symptoms, you need to think acute limb ischemia, and you need to act fast. Now, when you're doing your head-to-toe assessment, these are the more chronic changes you're going to find. Because of that poor blood flow over time, the skin becomes thin, pale, kind of shiny. The limb itself will feel cool to the touch. You'll probably notice hair loss on the lower legs. That's because the follicles just aren't getting enough blood to grow hair anymore. The toenails get thick and brittle, and of course, those peripheral pulses will be weak, thready, or maybe even completely absent. So, we suspect PAD based on the patient's story and our own assessment. But how do we actually confirm it? And more importantly, what are we going to do about it?
let's dive into the diagnostics and the main pillars of treatment. This is everything for diagnosis. The ankle brachial index, or ABI, is a really simple, non-invasive test. We just compare the blood pressure in the ankle to the pressure in the arm. See, in a healthy person, they should be about the same, giving you a ratio of 1.0 or a little more. But a ratio of less than 0.90, that confirms that there's a blockage somewhere in the leg, and that confirms the diagnosis of PAD. Medical management usually involves a few key teams of drugs. We've got antiplatelets like aspirin that make the blood less sticky, which helps prevent clots from forming on those plaques. Statins are absolutely crucial for lowering cholesterol and keeping those plaques stable. Of course, we control blood pressure with antihypertensives, and sometimes a specific drug called cilostazol is used to help with the symptoms of claudication itself. I like to think of pad management like building a structure that's supported by three main pillars. But as you can probably see, one of those pillars is way, way bigger than the others. That's lifestyle modification, and the absolute bedrock of that pillar is smoking cessation. I'm telling you, without it, the other two pillars, medications and surgery, are just so much less effective. All right, this is where we come in. This is our wheelhouse. Let's really focus on the absolute priority nursing interventions and the super high-yield education points you need to give your patients to keep them safe. Okay, so as a nurse, you're constantly assessing pulses and checking skin. That's a given. But the two huge actions here are positioning and activity. You want to keep their legs in a dependent position. That just means down. So you can let gravity help pull that precious blood down into the feet. You also want to encourage a structured walking program. And so importantly, you have to protect their feet. Poor circulation means poor healing and reduced sensation. So a tiny little injury can become a massive problem. That's also exactly why we avoid heating pads. They can cause severe burns that the patient might not even feel happening. This slide makes it so clear. For PAD, we want the legs down. Dangling them over the side of the bed actually uses gravity to help get blood to the feet. Elevating the legs on pillows works against arterial flow and will just make their ischemic pain worse. So burn this into your brain. Arteries hate elevation. Your patient education. This is what prevents serious complications, like amputation. The message has to be direct and clear. Stop smoking right now. Check your feet every single day for any cuts, blisters, or sores. Wear comfortable, well-fitting shoes. Never, ever go barefoot. Don't cross your legs, since that can compress the arteries. And if your feet are cold, use socks, never a direct heat source like a heating pad or hot water bottle. All right, team, let's put it all together. This last section is all about cementing the key concepts and contrasts that are most likely to pop up on your NCLEX exam. I can almost guarantee you're going to see a question on the NCLEX that asks you to tell the difference between arterial and venous disease. This table is your cheat sheet. Just remember this. PAD is a getting blood down problem, so we put the legs down. Venous disease is a getting blood back up problem, so we put the legs up. Seriously, that one distinction will help you answer so many questions correctly. Okay, here it is, your rapid-fire review. These are the absolute, must-know, non-negotiables. PAD equals arterial ischemia. Claudication gets better with rest. The ABI number for diagnosis is less than 0.9. Legs go down. Smoking cessation is priority number 1, and a massive, massive safety alert. Never, ever apply compression stockings to a patient with significant PAD. That's a treatment for venous problems. Using it for an arterial problem is like standing on a garden hose that already has a kink in it. You'll just completely cut off the flow, and you could cause limb loss. So let's end with one final clinical judgment scenario. Your patient, who has a known history of PAD and that classic intermittent claudication, suddenly calls you and says the pain in their leg is now a 10 out of 10, it's constant, and their foot feels like a block of ice. Which of those 6 Ps are you seeing right now? And what is your absolute first priority as the nurse? Think about that, because that is the kind of critical thinking that saves lives and limbs.